Now we move to another part of this session. We will look to the future. Now we have two presenters which will highlight an aspect. The first is Mona Saraiya from CDC, who will discuss the interaction between screening and vaccination.
Okay, great. Good morning. I'm Mona Saraiya from the CDC, and I apologize, I'm a little late. I was writing a script with somebody from Grey's Anatomy in the other room. So in the United States, we have new cervical cancer screening guidelines, and I know this whole session's about that, so I just wanted to highlight the last row, screening among fully vaccinated. The American Cancer Society with ASCCP reviewed those guidelines, as well as the American College of OBGYN, and basically the guidelines are remaining the same for non-vaccinated cohorts. The U.S. Preventive Services Task Force did not review this particular issue. So why didn't guidelines change for the vaccinated cohorts in the United States? It has a lot to do with the vaccine coverage. We not only have low first dose vaccine, but we have low completion rates. It's unclear when the vaccination is occurring. Generally, the vaccination in the United States is occurring a little bit later than 11 to 12-year-olds. And so we're not sure if it's occurring necessarily before sexual debut or after sexual debut. The US is an opportunistic screening system, not organized. Our medical records don't connect. The screeners don't know what the vaccination records are or even the screening history, and therefore we often screen on a much more regular basis or frequent basis. The other issue is that we're waiting to actually see the impact on lesions and disease versus relying on modeling completely. And in this guideline review process that I was part of with Barbara Moshkicki and Eduardo Franco and another group of people, there was a lot of controversy about individual screening. If a physician knew they were in a closed system, would it be possible to change screening behavior versus population-based screening? And we tackled both, and for both issues, we had decided that it would be best not to change screening practices. But let me tell you a little bit about how, why we have time to think about this issue. First of all, this is a model looking at by Harold Chesson, looking at the indirect effects of vaccination as well as the direct effects. And basically what you're seeing is that it's going to take a while, given our low coverage, for us to actually see the impact on CIN3, let alone CIN2. So if you look at this, the lower line shows a high coverage scenario, 3-dose coverage, 75% at age 12. And the dashed line is a low dose coverage, 30%. You can see that it's going to take at least 10 years if we have high dose coverage to see an impact. So there was also the thinking that this is not an urgent issue at this point. Screening needs to be more efficient regardless of vaccination status. If one is not vaccinated, we already have guidelines that say do not do annual screening, screen later at age 21. There was actually substantial debate about even whether we should consider screening at age 25. Screen with HPV, which is a new guideline. But for a vaccinated population, we expect a decreased HPV prevalence, specifically 16-18. Our Pap test characteristics will be affected. We anticipate a decrease in procedures as well as abnormal cytology. And there is a discussion about changing the strategy to HPV-based screening. This is a slide by Phil Castle and Cosette Wheeler, basically modeling what we anticipate the impact would be if 16-18 was out of the picture, using seer cancer rates. Excuse the slide, it's a little bit off, but basically you can see that the blue line is what cervical cancer rates are with all HPV types, but if you take 16 and 18 vaccination into account, the rates of cervical cancer would be substantially lower on the red line. And those are age-specific rates. But cervical cancer still needs to continue. Why? Because we know that 16 and 18 cover 70%, and even if you include those types that'll be in the nanovalent vaccine, approximately 90% of cervical cancer cases will be covered, but there will still remain a substantial proportion that will not be covered. This is a courtesy of Jane Kim, reviewing some of the models that have been done in the United States as well as outside of the mostly developed countries, looking at what would be the cost effectiveness of cervical cancer screening in an HPV vaccinated population. And the left hand are the authors, the middle column is the country, and you can see that some of the strategies that have been highlighted in the third column review and look at options such as 5-year cytology screening with HPV triage, with screening starting at age 25, and then HPV with cytology triage, with screening starting at age 35 for that group. There's been groups from Spain as well as Europe that have looked at various scenarios, but the bottom line is that the screening strategy would need to change. One of the concerns in the United States is, what are women's behaviors related to screening, and is it going to change if one is vaccinated or not? This is a relatively new data looking at our behavioral risk factor surveillance survey in the United States, showing that this is self-reported data, even before the guidelines were put into practice in 2012, we see a decreased rate of women getting screened at a younger age. So something is occurring, whether it's a sea change in terms of highlighting harms, whatever, but something is occurring where we're seeing a decrease of approximately 65.3% of women reporting in 2002 between the ages of 18 to 21 having been screened at least one, to now a decrease all the way down to 41.6. From the literature, much of HPV vaccination is occurring later than recommended ages, as I mentioned before. In some studies, we see that almost 100% of women, 18 to 71, know that HPV vaccinated women should continue to receive Pap test, which is often a concern that's been highlighted in many studies. Another survey has shown that most women 18 to 26-year-old who report being vaccinated actually have a higher intention to be screened in the future. And most women 18 to 26-year-old women who report being vaccinated have already received a Pap test. Studies from UK and Australia are a little bit variable, where some studies have shown that parents aren't sure that they should continue getting their girls screened or not. And some women in Australia aren't sure whether they would be screened as well in the future. What do provider surveys show in the United States? This is a survey that was conducted by the CDC in 2007, so relatively early after the vaccine was approved. And we were just trying to get a baseline assessment about what the intention was about providers in terms of whether they would change when to start screening and how often to screen. And this particular slide looks at when to start screening. So you can see that physicians definitely varied by their specialty, but generally most felt that they would potentially change when to start screening if a girl was fully vaccinated, received all 3 doses before sexual debut. But there was a significant proportion in the last row that weren't sure what to do. And we were just using this as a baseline. You can see here again, this is assessing the frequency of whether they thought a girl that was fully vaccinated, received all 3 doses, would change her screening frequency. And again, you can see that there was a group that definitely did not agree and felt pretty strong about it, especially certain specialties. And recently, there was a survey that's in press or just released by Bruder et al. That showed that 81% of physicians reported not planning to change Pap smear frequency for vaccinated women. Internal medicine physicians were significantly more likely than OBGYNs to report intentions to change frequency for vaccinated patients, which is consistent with most of our provider data. And other factors that were significantly associated with intention to change frequency were self-identification as a late adopter of new vaccines, being in a solo practice, and practicing primarily in a clinic or hospital-based setting. One thing that we need to keep in mind with vaccination and screening and the integration of the two is disparities. This is a map, courtesy of Diane Solomon, that basically looked at different states and the high uptake. So what you see here on the left-hand side is that wherever there's a low mortality in the states in the United States that have low cervical cancer mortality, the vaccine is actually had a much higher uptake. And on the right-hand side, some of the southern states where there's a traditionally higher mortality of cervical cancer, the vaccine has actually had a low uptake. So this is something to keep in mind when we're talking about integration of screening with vaccination, that are we reaching the right populations? Are we going to be screening the girls that are vaccinated and create a further disparity? From the National Immunization Survey that the CDC conducts, we see that for first dose, we actually do not see the racial ethnic disparities. And this is a slide looking at race on the bottom. And the rows are looking, the bars are looking at or above poverty, below poverty, and unknown poverty. And you can actually see in this particular slide that African American populations and Hispanics actually have a pretty high coverage rate regardless of poverty for first dose. But when you look at the 3-dose, that's completion of all 3 doses, that's where you are starting to see some disparity between the first and the 3rd dose. The last thing that I wanted to bring to fruition was surveillance, how important it is in this time where screening and vaccination are being introduced to monitor these behaviors as well as outcomes. And we need to have systems in place. The US doesn't always have these systems in place, but we do have special studies that are occurring in parts of the United States, including New Mexico, many of the CDC emerging infection disease programs, where we need a vaccine registry, an HPV outcomes registry, an organized program, if that's possible, where one can look at what the outcomes are. But outside of the United States, many countries are already contemplating change. For example, Australia and England both have high vaccine coverage. They currently have the youngest, Australia currently has the youngest age to start screening, 18, and they screen every 2 years. But what they've got going for them is that they've got an established HPV vaccine registry and a Pap test registry. England, currently screening at age 25, also has an established screening registry. But change is coming. In fact, Australia has started a formal review of screening. It's called the renewal process, and including consideration of primary HPV screening. And how they're doing it is in different stages. First, they're doing a literature review, as well as modeling, followed by a data and quality system and patient acceptability evaluation in 2014. And they're also investigating primary HPV versus cytology in a trial that I'm sure Karen Canfell will be talking about later on. In the UK Screening Committee has already established that one can do primary HPV testing. This is being followed by cost-effectiveness modeling of primary HPV screening in England based on artistic trial, and funded by the NHS National Cervical Cancer Screening Program. There will be some results that will be provided during this meeting. I believe it's on Wednesday. And there will be a planning pilot evaluation of primary HPV screening in areas already using HPV as a triage test. So there's definitely a paradigm that's occurring with Pap cytology. It's may no longer be suitable as a primary screening test. And high-risk HPV DNA offers a lot of hope because it's more sensitive and reproducible, it's likely to vary in sensitivity and specificity, and cytology will also perform better in the artificially high lesion prevalence when you triage HPV-positive women. The additional benefits include serving a second purpose, because this could be a surveillance system integrated with vaccine registries to monitor vaccine efficacy, duration, and cross-protection. You're going to be impacting adenocarcinomas, reaching remote areas because self-collection of cervical samples could potentially increase coverage. It's simple in terms of the guidelines, and it's safe in terms of extending screening intervals. And one of the things that's especially of concern in many countries that have cytology-based workforce is that cytology will still be an important screening strategy, but perhaps as a triage. So in conclusion, we do not have no change in current guidelines for vaccinated cohort, but in certain settings it's plausible that screening among vaccinated cohorts can occur later and less frequently, especially when you're in a system where you know records, such as a managed care organization. It's important to integrate vaccination and screening to maximize public health benefit while avoiding harm to women and looking at cost effectiveness of cervical cancer prevention. As I mentioned, it's important to do continued surveillance to monitor how uptake of vaccine influences screening practices, use vaccines' impact on future screening recommendations for a more rapid adoption of screening later and less often, and changing to primary HPV testing. Because basically we're in a paradigm shift. Right now we've established the screening guidelines, and we're still trying to extend the screening interval. And I think it's also important to explore the best methods for educating women about optimal cervical cancer screening prevention strategies, and that it's being observed as an important public health strategy, not just purely trying to save costs. And I'd like to acknowledge the American Cancer Society Working Group 5, the CDC, NCI, and Jane Kim and Karen Canfell.